I'm Laurie Sehn, and I'm a hematologist-oncologist, and I'm here at the ESH meeting on lymphoid malignancies with my colleagues, Dr. Buske and Dr. Falini. And we're going to review a little bit in terms of the content of the meeting, what we thought was most interesting and will likely guide future therapy in lymphoid malignancies. So perhaps we can start a little bit with indolent lymphoma and Waldenstrom's. We learned quite a bit at the meeting about the translational aspects of how our insight into biology is changing, and certainly how treatment is changing very quickly.
Yeah, so as you said, I think it was a very exciting meeting because it really demonstrated that insights into biology can be guide, actually treatment development. And I think there were two examples. One you already mentioned, Waldenstrom, but also perhaps follicular lymphoma. So one also major topic at this meeting was the impact of microenvironment for indolent lymphomas, how microenvironment shapes actually clinical behavior of indolent lymphomas. And we have good data for follicular lymphoma that this is the case. We know for a long time that follicular lymphoma can regress spontaneously without that we do anything, already hinting to the fact that the patient's microenvironment might play a role. And now we have good data demonstrating that actually follicular lymphoma crosstalks with the microenvironment in a very sophisticated way. And this has fueled actually also treatment development. And there are examples such as the checkpoint inhibitors, for instance, which try to reactivate the T-cell response against the patient's lymphoma by blocking an interaction between antigens which are expressed on the cancer cells, such as PD-L1, and the receptor on the T-cells, PD-1, which actually leads when they interact to, if you want, so like a sleeping pill, like leads to a paralysis of the T-cell response. So this is, I think, a very intriguing concept, these checkpoint inhibitors. So this was a topic. And another important field in the follicular lymphoma treatment are immunomodulatory drugs, such as lenalidomide, which actually show, in combination with the anti-CD20 antibody rituximab, high activity. And there, at this meeting, there were data presented from the so-called AUGMENT trial, which actually tested this approach in relapsed follicular lymphoma. It was a randomized trial testing rituximab lenalidomide versus rituximab placebo, and the effect is very strong in favor of the rituximab lenalidomide combination. So this was a little bit for follicular lymphoma, and another aspect more in Waldenstrom was that we learned from genotyping that we can actually categorize lymphomas such as Waldenstrom in different genotypes, and we learned that these genotypes have a different sensitivity towards kinase inhibitors such as ibrutinib, and that we actually use these genotypes to decide on treatment in patients even outside of clinical trials.
So going back to what you do in clinical practice, I mean, in my own center for follicular lymphoma, we still start treatment with bendamustine and rituximab as our sort of preferred chemoimmunotherapy approach, followed by maintenance rituximab. What is your take on what standard frontline therapy for indolent non-Hodgkin lymphoma should be? What do you do for follicular, and what do you do for upfront Waldenstrom's patients?
Yeah, so we are also responsible for the guidelines, so you think twice what you write in national and European guidelines. So we are cautious and say, so our standard is an anti-CD20 antibody plus chemotherapy followed by a maintenance treatment with an anti-CD20 antibody. Why this? Because we have the Gallium trial, which showed that obinutuzumab plus chemo followed by obinutuzumab maintenance is significantly superior with regard to PFS compared to rituximab chemo followed by rituximab maintenance. So what we say and what we do is, and there's a subgroup analysis demonstrating that follicular lymphoma patients with a high FLIPI probably benefit a little bit more from this obinutuzumab chemo approach. So this is why we say both is correct as a first-line treatment. You know, when you have a medically fit patient with a high tumor burden, many centers, and also our center, gives obinutuzumab chemotherapy, followed by obinutuzumab maintenance. When you have more low tumor burden, or because of the little bit higher toxicity of the obinutuzumab combination, then rituximab chemo is absolutely a valid standard option.
Mm-hmm.
But I think it also differs a little bit from country to country, I guess.
Yes, it does depend sometimes on access and funding. In terms of patients with Waldenstrom's, which of course make up a smaller group of patients that I treat in my own clinic, but nonetheless a very relevant and group of patients with unique biology, as you mentioned. There is, of course, mounting data on the use of BTK inhibitors and even data that suggests they could be used in the frontline setting. Do you have an opinion on where those should factor in terms of the treatment algorithm?
So again, as you said, it depends a little bit on the country. So I know that in the US it's different, but so for us, a standard first-line treatment in a medically fit patient with Waldenström is still rituximab chemotherapy. So, and what is used most is rituximab bendamustine, but we emphasize always that you know, you should only use 4 cycles, and you should be very generous in reducing also bendamustine dosing to 70 milligram, for instance. It's fine. So we are a little bit cautious. Or we give DRC, which is Dexa, rituximab, and cyclo. It has the possibility to give it non-IV, rituximab sub-Q from the second cycle, and Dexa and cyclo orally. So this is in some way our first choice. Ibrutinib is the most effective single agent in Waldenström, that's sure. But you can keep it also for the relapsed situation, in particular when patients have a short duration of response, which happens. So also in Waldenström, there are patients who have quite clinically aggressive disease. There are even p53 mutations, and they run really catastrophically. So you can keep it. Or when you have a more medically non-fit patient, first line, not tolerating chemotherapy, then of course ibrutinib first line is also fine. And when I may add, again we come back to biology, which was the major topic here at this meeting. When you have the MYD88 gene and the CXCR4 gene non-mutated in Waldenström, think twice before you give ibrutinib, because data quite robustly show that you actually have no chance to get the patients into a partial remission with ibrutinib when you have this constellation.
Why don't we shift gears a little bit to hairy cell leukemia? And I think for those of us that treat lymphoid malignancies, we see a few patients every year, and I have to say they always represent a challenge in my own clinic. Perhaps you can tell us what you feel the current state of the art treatment is in the frontline setting, and where you see the field going in terms of novel therapies.
Hairy cell leukemia is a very curious disease that can be diagnosed because of the typical morphology, that is the hairy projection. The patient usually present with pancytopenia and splenomegaly in absence of lymphadenopathy, so it's different from other chronic B-cell lymphoproliferative disorders. And the disease is very sensitive to purine analog such as cladribine and pentostatin that remain the gold standard as frontline therapy for hairy cell leukemia. However, 40 to 50% of the patients during the course of the disease have a relapse, and so there is room for improvement in the setting of refractory relapsed hairy cell leukemia patient. And the breakthrough came from the discovery in our institution of the of the BRAF V600 mutation as the causal genetic event of hairy cell leukemia. And this has been immediately after the discovery translated into a better diagnosis for this patient because we have a genetic test now that can differentiate hairy cell leukemia from other disorder that morphologically can simulate hairy cell leukemia, such as hairy cell leukemia variant or splenic marginal zone lymphoma.
Maybe I can just stop you right there.
Yeah.
So I didn't realize that the mutation was so prevalent. Now, what percentage of patients with true hairy cell leukemia have the mutation?
Virtually all of them.
Virtually, so it's 100%.
We have only, in a series of 180 patients, we observed only 2 cases which were BRAF unmutated. And we are investigating these cases by whole exome sequencing. But this is an extremely rare event, so every patient will have the mutation, and will have the mutation in the entire cell population, as you can demonstrate using antibody which are specific for the mutant in bone marrow biopsies. And you will have this mutation even after 20 years for the first diagnosis, after multiple lines of therapy. We never observed disappearance of BRAF mutation in hairy cell leukemia. So this is we thought that this is monogenic disease like acute promyelocytic leukemia or chronic myeloid leukemia. So this is a really a genetic causal event of the disease. So in a way, an optimal target for therapy. So this is the reason, because in the setting of the refractory relapsed patients, we have used the BRAF inhibitor vemurafenib. We chose vemurafenib because it was the first BRAF inhibitor we had available, and we used the same dosage of 960 milligrams twice a day as it was used previously in the melanoma trials, BRAF mutated melanoma. And the first trial we ran was with vemurafenib alone, and the results were quite good, because we had an overall response rate in heavily treated patients with a median number of previous therapies of 3 of 96%, with about 65% of partial remission and 35 complete remission. However, in none of these cases, when you investigated the bone marrow biopsies at the end of therapy, you could find a complete cleaning of the bone marrow by the tumor cells. So by immunohistochemistry, there was always some residuum of 5%, 10% of CD20 positive cells, positive vemurafenib. So there is a fraction of vemurafenib resistant cells in this patient. Although the patient, of course, they go into complete remission that in this hairy cell leukemia trial is defined by morphological criteria alone. So this is the reason, because we have started and completed a second trial using vemurafenib plus rituximab with the rationale to eradicate this residual disease with the immunotherapy. And these data are not yet published, and the results are markedly improved, because now we have with the combo therapy a rate of complete remission of 96% versus 35%. We have a minimal residual disease negativity in about 65% of patients versus null of patients with vemurafenib alone. So and this is with a long median follow-up of 24 months. So we have only one patient we achieved the negativity for minimal residual disease out of the 17 that relapsed at the minimum follow-up of 24 months. So I think that this therapy may have the challenge to be compared with conventional therapy in a frontline setting.
Yes, I have to say those results are extremely impressive. Do you think that we're actually curing some of these patients with hairy cell leukemia?
At this moment, I cannot answer exactly to your question because we are following this patient with a minimal residual disease negativity. So only the follow-up will tell us whether this. However, it will be a very long follow-up because these hairy cell leukemia cells have a very low proliferative index, so it would be necessary to follow this patient for a long time, yes, for saying that the disease is really cured.
But certainly there's reason to be optimistic that outcomes are really improving for these patients.
This patient,
Well, from myself and what I learned at the meeting, I guess a big focus of my attention was based on the information on diffuse large B-cell lymphoma, which is still one of the most common lymphoid cancers that we encounter. It's in many ways still one of the most frustrating. Patients present with very aggressive disease, and we've had a standard therapy that's been around for decades that has the opportunity to cure patients. So patients with diffuse large B-cell lymphoma treated with R-CHOP, which is still the current standard, about 65% of those patients will be cured. But what's been really frustrating, of course, is that after 20 years of this standard therapy, we still know that 35% of patients will be resistant or refractory. And of course, there's a lot of research going on trying to understand the heterogeneity of patients with diffuse large B-cell lymphoma. We've had 2 decades of understanding that through gene expression profiling, there are at least 2 molecular subtypes that we often call GCB and ABC subtype, but now, of course, some very elegant gene expression profiling studies where we see that patients will, based on mutational analysis, can be clustered into even a bigger group of biologically distinct patients. So we spent some time reviewing some of the recent data and trials trying to bring in novel agents into the frontline setting combined with R-CHOP, and most of these trials have selected patients based on their cell of origin because the targeted therapies have had preferential activity for the ABC subtype, but unfortunately all of these trials so far have been negative. So somewhat frustrating that we've been unable to change the current standard of care. But what is also compelling is that there are a series of novel agents that are coming down the line in terms of trying to treat patients with relapsed and refractory disease, including various immunotherapy approaches, bispecific antibodies, and I think we look forward to more data on those agents and how we might in fact test them in the frontline setting. I think diffuse large B-cell lymphoma really is that sort of problematic area where we do need to get more creative in how we design our clinical trials to give ourselves the best chance of success in terms of perhaps pre-selecting patients that are going to benefit the most, either based on biology or some other definable factor, and hopefully find a way to more efficiently test some of these novel agents. I think that one of the highlights from the meeting for me was the last session where we also focused on novel clinical trial design, and that really has implications for all the lymphoid malignancies where we've got many novel agents in development, and we really need to figure out how to prioritize those agents and how to best study them in the various subtypes that we see. So I'm going to put you on the spot a little bit maybe, and as we summarize and end up, maybe ask you, Dr. Buske, to tell us what was your big highlight of this meeting?
I think it was, for me, it was not one highlight, I would say. So I think what I really liked at this meeting was, the interconnection between researchers, bench to bedsides. And I think you cannot separate it anymore. So this is why I think to have such meetings is so important, the cross-talk between PhDs and MDs, so between biologists and us clinicians, because biology really impacts. Yeah, we see this, and without understanding the biology of these diseases, I think progress will be very tough. I think the time where we just can give chemotherapy to all comers, I think that's over. I think this was like a red line throughout all the sessions, and I think this is the way to go.
Dr. Falini?
Yes, I have the same feeling that this connection between basic research and clinic is fundamental, is critical. And this reflects also the nature of the participants, which were, I think, half and half clinician and half researchers. And I was also impressed by the number of questions during the meeting. Even in the session of rare disease, where the knowledge is, I thought it was inferior than in other settings. Yeah.
Yes, well, I would definitely echo your comments. I think it was a very comprehensive meeting. I certainly enjoyed the interactive format, and of course we all look forward to the next meeting.